Welcome to AETCM, the Emergency Medicine Channel. Today I'll be presenting a case of a 29-year-old male patient who presented to our ER with alleged history of slip and fall while stepping onto a puddle of water, and he fell on his left outstretched hand. On initial 10-second assessment, patient is conscious and oriented. Patient airway, breathing, circulation, everything was stabilized.
Okay.
All vitals were stable.
Okay.
On this, further examination of the local examination of the elbow, the whole attitude of the limb, patient was holding his hand in a flexed position. Flexed position
Okay.
with and there was on inspection there was a deformity seen at the elbow.
Okay.
With the 3-point bony relations were disrupted.
Okay. What is the classical 3-point?
Classically, if it is in a flexed position, you will have an isosceles triangle formation. Or if it is in a extended position, you will have a straight line formation.
Okay.
So in this patient, it was not an isosceles triangle position, and he was catching it in a supine flexed position. And further, we had seen a swelling around the elbow, and further on palpation, there was swelling with tenderness was there. And further, we had seen for the neurovascular deficits. We had examined for any involvement of the ulnar nerve, median nerve, and radial nerve, and there was no sensory deficit, and motor for the same was also checked, and vascular pulsation, ulnar and radial artery pulsations were checked.
Which vessel is more prone to get injured with this?
If you are suspecting elbow dislocation, most commonly brachial artery is what is commonly
Getting
injured.
Okay.
And followed by ulnar artery, and radial artery rarely injured.
Okay.
And we checked for both pulsations which was intact.
Both three nerves can commonly get injured, but ulnar nerve is
Ulnar
very
nerve is the
common.
most common injured, then followed by median nerve, and then rarely radial nerve
Okay.
get injured. And after that, after checking the neurovascular deficits, we had proceeded. We had not done any manipulation at this point, and we had
Analgesics
proceeded.
given?
Analgesics. We had put a 18 gauge IV cannula, and PCM
Okay.
IV was given.
Okay.
And further, we had sent a patient for X-ray of the elbow, AP, lateral, and oblique views we had taken, and also we had taken informed consent from the patient for giving procedural sedation. So for this patient, is 29-year-old male with no comorbidities. So we had went ahead with midazolam 1 mg, and
So what was the findings in the X-ray?
X-ray findings. We had seen actually a dislocation, which is a posteromedial dislocation.
Posteromedial or
Posteromedial.
Which is most common?
Most common is posterolateral dislocation. In
Okay.
this patient, we had seen a posteromedial dislocation.
Okay.
And
What does an elbow dislocation indicate? Why you have what does the most when you see a patient with elbow dislocation, what is the most important thing that you should keep in your mind? The force. Because elbow, usually when you have fallen an outstretched hand, it will not get dislocated. If the elbow, there is a significant dislocation, the impact and the force of injury is that much.
Yes.
So you can have associated fractures.
Fractures.
So what are the associated fractures that you want to look into the X-ray, which we can easily miss?
so fallen outstretched hand, usually patient can have fractures at the level of wrist.
Level of wrist, radial colies and all, you leave it. Around the elbow joint.
We can have the most common is radial neck fracture.
Okay.
And followed by radial head fracture.
Okay.
And then we can have the supracondylar fracture, and other epicondylar fractures.
You can have a separate epicondylar fracture or even olecranon process. Olecranon fracture also can be there. There can be isolated radial head dislocations also associated with this, which we can easily miss. So these all things we need to go through the X-ray. So again, when we discuss X-ray, when you have to discuss a pediatric elbow, it's totally a different perspective. So pediatric elbow, the ossification centers and all will not have formed. So that we'll discuss in another day. But an adult patient, what primarily we need to look in for is the three things. Most importantly, one is the any other fractures are there. What is the type of dislocation? Posterior, lateral is the most common one. But here we have posteromedial dislocation, and there are certain lines like radiocapitular line. Then there is an anterior pad of fat, which usually will, if there is a radial head fracture and all, you will see this anterior pad of fat getting dislocated. So we can have a joint effusion also. The anterior pad of fat will get dislocated. So we'll get position, it will be pushed posteriorly. So instead of that, it will become a posterior pad of it. So all those things you need to look into the X-ray. So these are the common things that you need to look in for. Then comes the maneuver that you are going to discuss is the posterior dislocation. We have confirmed it is a posterior dislocation without any fracture. You are planning for an ED procedural sedation.
We had also actually went ahead with CT of the elbow as well. In that it showed a chip fracture at the coronoid process.
Coronoid process. So coronoid process. Why there is a coronoid process fracture? Because of the stretch, you can have a slight chip fractures can happen. Okay.
And then we had went ahead with the informed consent. Two ways we can approach this. Either we can go with the procedural sedation, or we can even try an intra-articular injection of anesthetic. So here we had went ahead with the procedural sedation. So informed consent was taken.
Okay.
And we went ahead with, since it's a young age with no comorbidities, we went ahead with midazolam and ketamine
Okay.
sedation, and midazolam 1 mg and ketamine 30 mg.
0.5 mg per kg.
0.5 mg.
Okay. Okay.
So 30 mg we had initially given.
Okay.
And followed by that procedure we had done. First of all, we'll have
And
to
demonstrate how many persons ideally needed.
ideally 2 to 3 persons.
Needed, and you should have adequate strength while pulling this also. It's not an easy procedure. You should have exert adequate force during reduction. Can you
So,
just show that? Ideally, the patient should be in a lying down
supine
position.
Patient should be in a supine position, and we should be flexing the elbow to around 30-degree flexion position, and we'll ask another person to be giving counter traction at the humerus, and then
The axial direction. You
axial
can
direction. And here we'll be giving the traction at the level of forearm, and we'll give maximum traction.
Traction,
for some
counter
time.
traction.
Counter traction for some time, and followed by that we will be giving a press on the olecranon, so
Okay.
that falls into the olecranon fossa. So once we hear a sound, we will,
Click.
click sound, we can feel. After that, it will be put in place, and we can just check for the range of motion, and we can keep it in a flexion position. And
immediately
place
post reduction. What do you need to do?
post reduction, we will have to X-ray, have to take,
Before
and also
that.
neurovascular.
Neurovascular deficit. Check for the radial artery.
Again, we have to check.
Reassess the neurovascular structures. Then you ask for a posterior slab, and position of the posterior slab should be in. What should be the position of the posterior
Maximum
slab?
flexed position.
90-degree minimum we have to do. 90-degree, and this should be the position in which you are giving a posterior slab, and they should be reviewing after a couple of weeks in orthopedics OPD. So you can take always a check X-ray also. Okay.
And after that, we'll have the most common complication it can lead to is any stiffness it can develop. So after 5 days, we have to advise the patient to do range of motion exercises gently. And also it can we have to apply this slab for at least 3 to 6 weeks, depending on the severity.
There is already a chip
And if
fracture,
there
so
is
you need a little bit on the longer
Longer
side.
side. And if it was a bigger fracture, we will have to take up for internal fixation as well. And also other common dislocations are, we can have isolated lateral or medial dislocations. In that we will have to keep not in a flex position, but more of a hyperextended
Hyperextended
position, little extended position, and do the same maneuver. And for anterior dislocation also, in a flexed position, while giving the traction, we'll have to press from here, front backwards. You will have to press
Because
for
it's anteriorly
anteriorly
dislocated.
dislocated. That is very rarely
occur.
occur when it has direct impact on the elbow.
Okay. So in a nutshell, you can have isolated elbow dislocation without fracture also. So our aim is to, most importantly, you cannot miss a fracture. So that is the reason why we went ahead with a CT. So the radial head fractures and all, sometimes we can miss because of the high impact. Whenever you see a elbow joint dislocation, it's a high impact injury. So that's the first thing that you should strike in your mind. Always look for the distal neurovascular injuries
Before and after.
before and after reduction. Also, you need to look, and it's a simple procedure which can be done under sedation in the ED without much complication. And the slab, whatever you are applying, it should be therefore, and they should definitely need a follow with an orthopedician. Okay, fine. Thank you.